Thank you to these companies and organizations that make the Before I Die New Mexico Festival possible. A good goodbye. Gail Rubin puts the fun in funeral planning. Compassion and choices, improving care, expanding options, and empowering everyone to chart their end-of-life journey. Daniel's Family Funerals and Cremations, Fairview Memorial Park, Gabaldon Mortuary, Sandia Memory Gardens, and Vista Verde Memorial Park, all in the Albuquerque area. Estate Pros, offering professional dispersal of personal possessions due to a move, illness, or death. The Final Exit Network, educating about and defending the right to choose at end of life. French Funerals and Cremations and Sunset Memorial Park in Albuquerque. Gathering Us, providing in-person and virtual memorial services and online memorial pages. Keeper, providing hybrid and virtual memorial services and keeping memories alive with online tributes to preserve, celebrate, and share life legacies. Morris Hall, estate planning attorneys in New Mexico and Arizona. Remembering a Life, your guide to honoring a life well lived, from planning a tribute to mourning a loved one. And Retirement Extender, investment management services with a personalized strategy recommendation based on your needs and objectives. We are excited to go into day 3 of our Before I Die Festival events, starting out with this very important topic in New Mexico about accessing medical aid in dying. Our 2 speakers this morning are the experts on this topic. Barak Wolff is the board chair of the newly formed End of Life Options New Mexico nonprofit organization. He's a longtime public health leader in New Mexico, and he worked to get medical aid in dying passed in the state for many years. And we also have New Mexico State Representative Debbie Armstrong. She is a champion of the medical aid in dying cause and was the sponsor of the bill that was passed earlier this year and signed into law by the governor. So now we have this law. What do we do with it? How do we access it? And both she and Barak are going to give you an overview and answer your questions. And by the way, Debbie has more than 35 years of experience in healthcare and public policy. So they both know what they're talking about. So Barak, take it away.
Well, thank you so much, Gail. Always a pleasure to be here. First thing I'm going to do is share my screen. We're going to go for a few slides today. Good to be here, always fun and worthy, always worthy. And the first thing I wanted to do was celebrate the weekend and share my very favorite Halloween slide. And, you know, always enjoy moving that forward. And then I want to, just honor one of, the really important guys in this whole movement of thinking about aging and end of life, surgeon and also a tremendous author, Atul Gawande, who reflected that life is meaningful because it's a story, and in stories, endings matter. And after all, that's very much what we're about. So here's today's story. I'm going to go very quickly through the front end of this, and I'll do this part about our right to self-determination and how that leads to our ability for advanced care planning, and very quickly discuss what are these end-of-life options that you hear about, of which the newest one, and I'll be turning it over to Debbie, Representative Armstrong at that point, to go over our new law in New Mexico, the Elizabeth Whitefield end-of-life options. And then I'll sort of bring it back up to how's it going so far in the first 4+ months that it's actually been a legal practice and part of the medical care here in New Mexico. As I say, we'll move quickly so that we have a little bit of time for comments and discussion as we move through. I put my email and our website in the chat, and may still be there. And, let's go for it. So I love this slide because, it starts in 1800 and goes up to the present day. And, what it shows us is we haven't made much progress, we're still at 100% mortality throughout the world. And which just is another way to say that we are mortal beings. And probably don't need to remind this audience about it, but nobody gets out alive. And just as we wish and we work hard for a good life, we can also seek a good death. And when I say that, some people sort of pull back a little. No, there's no right or wrong choices. The choices about how we may want to pass are really ours to make. And if we want to do the homework and make choices that we want to get behind and see if we can make work, it's up to us. And if we have some luck along the way, it might actually play out that way. There are no guarantees. But when you ask people, what would be the way you think you might like to die? Most people, 70, 80%, talk about a peaceful and pain-free death at home, surrounded by loved ones. And that always sounds pretty good to me. In fact, you see it in the obituaries pretty often, which is very encouraging. So-and-so died surrounded by his family after a long illness or whatever. And that always warms my heart because that is kind of what sounds good to me. But again, everybody's different. The reality, however, is that less than half people really achieve it that way. We're making progress in the last 10 years, but we have further to go. Many still die in institutions, suffering, often isolated with treatments that they may or may not wish to have because they just get caught up in the cycle of all that end-of-life specialty care and trying to extend longevity a little bit. So part of the mission here is how can this disparity between people, what people say they want and how it plays out, how can that be reduced? And this is the fundamental building block about which allows us to get to a better place. The New Mexico Uniform Healthcare Decisions Act was passed in the mid-1990s. We were one of the first states to adopt it. And it's a robust statement of rights with a lot of detail in it. It really gives us the ability to decide for ourselves what healthcare to have and when to start it and if and when to stop it. It also gives us a very clear right to appoint a surrogate or a proxy or a healthcare decision maker. Those are all synonymous terms. A healthcare power of attorney to act on our behalf if we lose capacity. And this is a really important thing. We could spend, an hour talking about how do you select a good proxy. Not today, but it's an important decision that we get a chance to make. And all of these things give us the opportunity to have that good death. As I said before, no guarantees. But it's good to know that the law is generally on our side, particularly if we choose to do the homework. And this right to self-determination then becomes the basis for what again could be an all-day workshop around advanced care planning. My hope is that folks on the call have taken care of that piece of business, but this is where you get to think through your values and your priorities and your choices for healthcare and end of life. And then after you think it through for yourself, you have that conversation with families and loved ones and friends and providers and advisors of all kinds. The more public you are able and willing to discuss your choices, the more likely it is that you're going to have it come out that way. And then, of course, there's some paperwork if you care to, and we recommend it strongly throughout your adult life. Completing an advanced directives forms, there's some terrific ones. There's one in the law, but it's also very flexible here in New Mexico. And essentially, I've heard some people say you could write it on a napkin as long as it's clear and you communicate what you want, that ought to be accepted. I myself would go for one of the standard forms, and there are some national forms like the 5 wishes and other kinds of things. And then you need to revisit these choices as life progresses, because we know that things can and will change. They change all the time. So, about a year ago, I started talking about end-of-life options, and it's always been part of our rubric as for those of us that were advocates. But then I realized that not everybody knows that what are these options that I speak of? And these are options for thoughtful dying. And some people choose to let nature take its course. Today's a good day to die. We've heard, stories of, elders in indigenous cultures sort of going out on the iceberg or going into the rainforest and saying, my time has come. And then other people who just say, I'm not going to bother with all that. I'm good with whatever comes my way. Sort of a hands-off approach. There's also the option of pursuing all the life-sustaining treatments that you can identify. And there are absolutely people, and I honor them, that say, I just want to keep living until my last dying breath. These are folks that sometimes I say wish to die with their boots on. And in our society and in others, if you can arrange that, and that's what you want, to try the various trials and experimental drugs and, go to a foreign land and see what they have to offer, I say go for it. But there also are those of us who have had a tough go of it. And as treatments arise, we may say, that's not a treatment that I want to try. I don't want to start that. All of those choices are brought to us by that Uniform Healthcare Decisions Act. And when you get into treatments, and again, people take one course of radiation and then they have some surgery and maybe they have some chemo. At any point, it is our prerogative to discontinue treatment and say, I've had enough, no more for me. And to help us make that decision in the last 20 plus years has been a terrific development in medicine called palliative care. And these are folks who go back for training or initially get trained in that fine art of helping people understand their options, looking at the various treatments that are going on between the various specialists that may be helping a patient with a complex medical problem, and helping evaluate the cost benefit of various possibilities for further treatment, but also looking at the implications of the competing medications and helping people stay as healthy as possible as they're taking their treatments. Palliative care consultation should, in my mind, go on as soon as you have a tough diagnosis, a terminal diagnosis, perhaps a life-ending one, or any serious illness. Get a consult who's going to focus on you, your family, and your options as things move forward. And then again, development over the last 30, 40 years, where hospice organizations, hospice agencies provide this wonderful wraparound, comprehensive set of services that for many of us call comfort care, where you make a decision that, okay, I'm done with treatment, and now I want to take what time I have left and be as healthy as I can be so that I can wrap up my life in the way I care to. And we're blessed these days to have a lot of hospice agencies. They provide good service with well-trained people. It's almost all in the home, but not exclusively. And again, you can learn more about hospice. Then we have a stopping eating and drinking, which is a way to hasten death and has been there for a long time. It's legal, it's ethical. And what we've learned is that it functions best when it's medically supervised. This is not something you want to try on your own because it can be challenging, and you go through phases in the week or two, or sometimes even 3 weeks, depending on the patient's condition. But stopping eating and drinking is a way to hasten death. And many, many people say that it can lead to a very peaceful and calm death as you proceed through the stages. Again, medical supervision is highly recommended. There's also something that continuous deep sedation or palliative sedation that is generally physician initiated, either in the hospital or perhaps in some places through hospice, where people have pain that can't be managed, intractable pain, or agitation, or cannot breathe, that air hunger that can be just so devastating. And they can basically be sedated. And sometimes that sedation can lead to sort of a coma situation and ultimately to death. but it's not the intention. This is really to relieve suffering, and therefore it's absolutely legal. And even the Catholic Church has given its blessing to this kind of relief of suffering. So that's there and can be requested and discussed with clinicians, but it generally has to be physician initiated. And then there's medical aid in dying, our newest option here in New Mexico. And it's really just a terrific honor to pass this off now to my good friend and colleague, Representative Debbie Armstrong, to help walk us through the Elizabeth Whitefield End of Life Options Act. So Debbie.
Thank you, Barak. And I'll go through this fairly quickly also so that we've got some time for questions. But New Mexico's End of Life Options Act was named for Elizabeth Whitefield, who was a beloved judge in the Albuquerque area, who was a strong advocate for this, for aid in dying. Unfortunately, she passed before it was enacted and was not able to take part in medical aid in dying. But medical aid in dying is the practice where a healthcare provider prescribes a medication to a qualified individual who may self-administer that medication to bring about a peaceful death. And we'll go through what the qualifications are. Next slide. It went into effect in June. So a qualified individual is an adult resident of New Mexico who has a terminal illness, and the definition of that is consistent with the definition that makes you eligible for hospice. So it's incurable and irreversible, and within reasonable medical judgment will result in death within 6 months. The person has to have the capacity to understand and appreciate the options that are available, including significant benefits and risks, and to make and communicate an informed decision. So they have to have, this is not something that can be delegated to a healthcare decision maker or a durable power of attorney. This option must be decided by the individual themselves. It's voluntary, so to the best of anyone's ability, it's not, the request is not being made under duress or undue influence. And there must be an ability to self-administer the medication. And self-administer is defined as taking an affirmative, conscious, voluntary act to ingest the medications. And I want to talk about this a little bit. This doesn't say that it's independent without any assistance, so that if someone can help you hold the glass, can help you get the medications ready, so forth. It doesn't have to be 100% independent, but it does have to be obviously in control of the individual who's obviously taking conscious, voluntary, affirmative action. And ingest doesn't say swallow. Ingest is taking into the gastrointestinal tract. And this is a question we get a lot. What if you can't swallow anymore? Throat cancer or advanced Parkinson's or whatever it is, or just uncontrollable vomiting. There is, and it's, there is a practice and ability to administer this through a feeding tube, or more commonly a rectal tube. So that is a practice that is a standard medical practice and can be done for anyone who can't swallow. The individual who can prescribe the medication has to be licensed in New Mexico, and it can be any kind of physician, so MD or DO, or an advanced practice nurse or physician assistant. Although if it's a nurse practitioner or PA, at least one physician must determine after conducting an appropriate exam that the individual is qualified. And this is different in New Mexico than other states, allowing a nurse practitioner or PA. And we did this because in New Mexico, Nurse practitioners have been independent practitioners for a long time, and PAs are almost within a breath of being independent, and both are licensed to prescribe the kinds of medications that are used. And for many people, that is who their primary care provider is and who their most trusted provider is and who they know the most closely. And in many communities around New Mexico, they're the only providers in the community. And so we thought it was important that you be able to go to the kind of practitioner who you are most comfortable with, who is duly licensed and able to prescribe. We also said in order to decrease some of the hoops you have to ordinarily jump through, is that if you're enrolled in hospice, that is a confirmation of terminal illness by a physician. As I said before, we defined terminal illness consistent with what qualifies you for hospice, and the rules of hospice require physicians and a medical director to affirm that someone meets the definition of terminal. So if your prescriber is a MD or DO and you're in hospice, they don't have to consult with anyone else. If your prescriber is a nurse practitioner and PA, and you're in hospice, they only have to consult about capacity and other qualifying qualifiers, but not the terminal illness. And so we're hoping to make this a little bit more accessible in a humane, practical way, while still maintaining adequate protection seen in other laws in other states. Capacity, as Barak said, we have a longstanding Uniform Healthcare Decisions Act, allowing you to make your own healthcare decisions. And that act from the 90s has provisions about determining capacity. And it starts from an underlying presumption that the individual has capacity to make a healthcare decision. And unless there is suspicion by the provider that they don't, the prescriber can decide they don't have capacity and just not ever pursue it. But they can also then seek a consult from a mental health professional. And we've said in the law, in addition, if there is a current or recent history of mental illness or disability that could impair capacity for end-of-life decision-making, they must be referred, and it can't proceed until that professional determines that they have capacity. An additional step that we took in New Mexico is we have a list of different people who are qualified to determine decisional capacity. Some states require that you get a mental health clearance, and some states require that it be by a psychiatrist, and that's hard to come by in New Mexico. So first we have that underlying assumption that you have capacity, and so only a few people are going to be asked for a consult, but then it can be psychologists, master's level social workers, psychiatric nurse practitioner, or others who are qualified to make that determination. So prior to prescribing, the provider must inform the individual of all available end-of-life care options, and Barak talked through those. And we specifically say they must talk to them about palliative care and hospice. And I will note that in other states, well over 90% of individuals utilizing aid in dying are on hospice. And so far, of the people that we know about in New Mexico who have utilized medical aid in dying, all but one have been on hospice. So that's not, as Barak was going through those end-of-life options, it's not all an either or. A lot of this can be done simultaneously. You can be on hospice, you can be receiving palliative care. You could even be doing the voluntary stopping eating and drinking if you wanted to, and still choose to do medical aid in dying. So the prescriber must document all the qualifications, and if they're enrolled in hospice, must affirm, or if necessary, affirm that terminal illness by a consulting provider. There is a form that is required by law that you must, the individual must sign requesting medical aid in dying. And on that form, you have to affirm that the provider has talked to you about all those other options and about the procedure and the risks and benefits and so forth. So it's not a form that's signed by the doctor, but it really is a form that should be signed after or upon discussion of this with the provider. And so it must be witnessed by two people, one of which must be a disinterested party. And this is the attempt to give some credence to the individual is not under undue duress in doing this. And then that form is included in the medical record. Once the prescription is written, there's a 48-hour hold until it can be filled, but the prescriber can waive that 48-hour if in their medical judgment, the individual might not survive that waiting period. And I will say this is the only waiting period in our law, unlike most other states that have a couple of weeks of waiting between, and other states modeled after Oregon. You have to ask your provider, then you have to ask again 2 weeks later, and then you have to get all the consults. And so in reality, it takes, in those states, can take 4 to 6 weeks before you can get your medication and do this. And many people do not survive that. They pass away while still in the process. Many people in hospice, while you can get on hospice with a 6-month terminal diagnosis, the majority probably don't enroll in hospice until weeks or days before the end of their life. So this is really a burden that we felt was an unnecessary barrier. So we made just that 48-hour, and it's waivable. And then the prescribing provider is responsible for reporting some information to the state. Other provisions in the law is that there is a right to know. This is separate and distinct from actually requesting aid in dying, in that the provider who has terminally ill patients must explain and discuss with their patients what all their options are. I think it's really important on the language you use, and medical aid in dying is not, and in the law is not considered suicide for any purpose. And that for any purpose would include death certificates, life insurance contracts, etc. This is not suicide. It will not say suicide or assisted suicide on death certificates. It will list the underlying condition and the natural death. There are very strong immunity protections and conscious clauses in the law to protect, and conscious clauses usually protect those who want to opt out. This also protects those who want to opt in and participate in aid in dying. No one has to. There is no provider, no individual who must participate under any circumstances, but there is also great protection from any repercussions should an individual choose to participate in aid in dying. Healthcare entities that choose not to participate must post that information publicly and provide a referral and medical records if requested. That referral does not have to be to another provider. They don't have to know what other providers are available. They can refer to an individual or organization such as End of Life Options New Mexico, who will help that individual find the help that they are seeking. And this is, as I said, not something you can delegate to anyone else. This is very patient-centered and patient controlled.
So thank you for that quick overview. We'll get to the questions and discussion. And again, also refer you, it's kind of on the screen a lot, our endoflifeoptionsnewmexico.org and our hotline number that returns the call pretty quickly for anybody that leaves a message. This is our new organization, End of Life Options New Mexico, that was created out of the group that was involved in the advocacy for so many years. We realized that this, and based on the experience of other states, this is not a law that implements itself. This is not something the public knows about a lot, although some do. And this is not one that our providers, our healthcare providers, know a lot about, unless they've come from another state like Oregon or Washington or California, et cetera. So we felt that to help implement this new law that we worked so hard on, that we would go ahead and form a private nonprofit. That's up and going. We've got our logo and our brochure, and we're building the foundation, looking ahead to being able to sustain a nonprofit for the future to help implementation, educate the public, educate providers, make sure there's training, that kind of thing. So how's it going? And as Debbie said, there's lots of interest and inquiries. We're busy. And we've already had a good number of these medical aid in dying ingestions that we know about, and that we've reportedly, the patients and the families are being well served, and we've had peaceful deaths resulting. We're all on a learning curve. We get calls all the time, but we've been supported wonderfully by our national partners. And there's a slide at the end that identifies those national partners who have years of experience in implementing medical aid in dying. We're very pleased that several hospice agencies have fully incorporated aid in dying into their practice, in some cases, including clinicians that will prescribe the medications. Other hospices are providing just supportive services as they normally would with somebody who's dying. And that's during the ingestions and with the family afterwards for bereavement and that type of thing. And some have decided not to participate at this time. And they've posted that message on their website as the law requests. And again, just want to be sure that that is fine. I mean, it's envisioned by the law that people have absolutely a right to opt out as long as they will refer and make sure that ultimately patients have an avenue to get where they want to be. In terms of the large systems, Presbyterian is supportive in their 7 hospitals across the state or more in their clinics, and they've developed some streamlined systems for approval and data collection and technical assistance and training. We are still waiting for more of their clinicians to come on board, but we think that they will as they get more experience. And just this last month in October, the UNM Health Sciences Center has completed their homework and got their systems and policies in place. And we understand that they've just started to provide services to their own patients. And I'm pleased to say that our organization has been able to help everyone that has approached us in finding a resource to see if they're eligible and then move forward with accessing aid in dying if they choose to go forward with it. So as I said, our nonprofit's incorporated. We've got subcommittees that are building our programs for outreach. And also we'll be providing that individual support and referrals to individuals. And we would certainly welcome your support. On our new website, we have a very smooth donate button, which I'm sure all nonprofits are anxious for you to exercise, but that's the only way we're going to be able to sustain our operation. So Debbie, just in the last couple of minutes, maybe you could just bring us back to a quick summary and then we'll open it up.
Sure. I think it can't be stated too much that medical aid in dying is not a failure of palliative care or hospice care. That can all be done at once. It's complementary when requested, but as Barak said, some may not want the palliative sedation because they want to be alert with their family when they pass, but they have uncontrollable suffering and a wish to make this an event, if you will, gathering family and friends, and know that they can say goodbye, and they can be in control of when and where. Doesn't mean that they aren't on hospice or aren't receiving palliative care. Having a conversation about all end-of-life options, including medical aid in dying, is palliative in and of itself, and it's empowering. And there are other states have shown us that many people get the medication and never end up taking it. Just knowing you can, just knowing that if tomorrow is too much, brings a lot of people quite a bit of relief of anxiety, which helps in anxiety doesn't improve pain management. So just knowing that you have the option is empowering, and having the conversation. And what we've also seen in other states is, once this is legal, actually the use of palliative care and hospice increases, because you have those conversations with your providers and you talk about those options and you access what you need in the end of your life. So these are all good things and complementary. And again, it's your decision. You must be capable of making that decision. It's not something you can pass off to someone else. So what can you do now? I would suggest that you talk with your own providers about their willingness to participate. It's good for you to know. It may, if you aren't terminally ill now, or if you're early in it, in your diagnosis, it may be of significance enough to you to change providers or begin finding someone who would be that the prescriber, and your own is just the affirmation that you're terminally ill. So, and always discussing these with your choices with your loved ones is a good thing. And again, as Barak said, if you have questions, need assistance, endoflifeoptionsnm.org. And we are answering emails and phone calls. We have volunteers organized to do that. And we've been organizing clinical presentations as well as public presentations such as this to help everyone get up to speed and knowledgeable about what the options are. So thank you very much. Here's again, End of Life Options New Mexico. Compassion and Choices and Death with Dignity National Center are our national partners and also have a great deal of information. American Clinicians Academy on Medical Aid in Dying is a support for clinicians. So there is a network of providers, clinical providers, who support and train other providers. And the Conversation Project is about having those conversations about your end of life choices. And I think we're open for questions and answers.
Yeah, just put up that last slide, remind us where we are in time and space. And I'm going to go ahead and stop sharing my screen and bring us all back together.
Good. Well, first of all, I want to congratulate you on the important improvements that you've made in the original Oregon model. At Final Exit Network, we've been, carefully monitoring all the different versions that have been in place over the years, and I think yours is definitely a step forward. So, congratulations with that. I hope it works really well for the New Mexicans. There is always one issue that we have dealt with nationally that I still see it might be an issue for you folks as well, which has to do with dementia and people being unable to access even a good model of death with dignity law like this one. And we have asked our legal counsel and medical ethicists, our MDs, and a hospice chaplain to invest in months of work together to produce a supplemental advance directive for cases like that. But the hope being that people, when they are competent and want to identify exactly what they want and don't want, when the window has passed, that would still be enforceable. And that's available free. So I would recommend you take a look at that. But my question actually is,
Okay.
How does that work in your state?
Sure. Well, I appreciate the question. I also appreciate your comment on our the changes we've made in the basic law. I think the New Mexico approach is actually right now already been incorporated into amendments of the California law. And there are a number of states that are looking at reducing waiting times and expanding who can participate. So I think it's going to serve us well nationally. But Gary, what you raise is not only true for dementia, but there are other conditions that ultimately have very long lifespans in themselves with lots of suffering along the way that ultimately folks can lose capacity at any point. And we're not going to meet all the needs. And I really appreciate you raising that. Dementia is one that jumps out, and the Final Exit Network has done terrific work in that regard, as have New York State and Washington State, where again, the approach is you can do a robust advance directive and perhaps still keep control of how that end of life comes down in regards, particularly to eating and drinking, and viewing that as medication. And when you get to that point in your life and saying, I get to control my medication. So we're very aware of it. And in fact, in most of our talks, we really do take the time to address the issue of those that we can't serve because of the restrictions in all of the bills about medical aid in dying. Debbie, did you want to add anything to that, or?
Yeah, I'll just add and thank you for your work in Final Exit. And I've said in other talks, I don't disagree with any of that. What we chose to do was what we thought there was political will to do, and it's consistent among other states. It's my hope that as more states enact this and it becomes more acceptable and more common practice and just part of standard medical care, that we figure out a way to address certain health conditions, including dementia, advanced or ALS or other conditions that by the time you reach a terminal stage, you may not have the physical or mental capacity to do this. So I'm hopeful that over time we can address that, but we chose at this point to do consistent with other states what we thought there was political will to do.
First of all, thank you and congratulations on the law. It just made me feel proud to be a New Mexican, knowing all the wisdom and everything that went into the law so that it's really accessible to people. I'm an end-of-life doula living in Santa Fe, and my question is regarding what can I do legally as far as like advising my clients? Like, I'm not a healthcare professional. My job in a lot of ways is to provide them with information that they don't necessarily have. So I see this as a key piece of information I can provide to my clients. I have links on my website to several different articles and things on MAID and VSCD. And the reason I ask is I was approached one time by someone in Canada who said that as a doula in Canada, I was breaking the law by providing information to clients. They said the law in Canada is really strict as far as who are the handful of people who can talk to a patient about MAID. So that kind of gave me a good scare. So I'm just curious. It sounds to me like, Debbie, from some of the things you went over, that there's some pretty good safety networks or safety clauses in there to protect people who are just providing information. But I just kind of wanted to hear from you as far as, is it okay that I have links on my website as a New Mexican end-of-life doula? And is it okay for me to talk to my clients about it? Not that I'm going to give them medical advice, but just to make them aware that it's there.
Absolutely. And I think that you are safe in New Mexico to do that. So our law is protecting participation, and it's participation at every level, applies even to family members who participate. So providing information, I think, is totally acceptable for you to do. The only people who are required to provide information on all options, including that are legally available, are doctors, nurse practitioners, and PAs in treating their terminally ill patients. They're required by law. But I think everyone else is able to provide that information. Links to our End of Life Options New Mexico.org on your website would be allowable, and links to other information. I don't see that anything would be precluded by that unless there is a specific, and I'm not familiar, if there's a specific preclusion in in your, and you're not, a doula is not licensed, correct? In New Mexico, you don't carry a license to be a doula, I don't believe.
And yeah, no, there's no licensing.
Yeah, there's no law that there's no,
Yeah.
I was going to say, unless you're licensed, you're precluded you from doing it, but you don't have a license in New Mexico.
Right.
So I think you're perfectly safe to provide whatever information you can.
Right. If I may,
Okay.
just a step further, Sherry, and thanks for being on the call today. I think death doulas have potentially, if they're interested, a very strong role to play in medical aid in dying. We've had conversations with death doulas throughout the state. They've been involved in our training activities, and I would welcome you to do that and express your interest on our website so you can get more understanding about how it goes down. Certainly, someone who's in relationship with a death doula, they may want to ask you to help them organize their event, those kinds of things. We have a small board of directors, and one of our directors is a death doula. And the ACAMAID organization that is referenced in the slide, acamaid.org, ACAMAID, they are within the next couple of months are putting on a major training program specifically nationally for death doulas. So I think there's roles to be played as volunteers or even in the work that you do for clients. So thanks for the good question.
Yeah, great. Thank you for the answer. Now I can be at peace.
Yes, please do.
Yes, I excuse me while I adjust with my kitty here. I'm an aspiring death doula and soon to be body worker, also known as massage therapist. And I'm interested, I guess you could say, in the details, because I'm still not as familiar with the medical aid in dying model. Is the actual procedure here in New Mexico, the actual medication, similar to other states in terms of how it works? I'm coming at it wanting to know, I guess, exactly how it works, if we have time for that today, or a reference to a scientific description of what I can expect if I chose to do it for myself.
Sure. Thanks for the question. We don't always include that, but people want to know what this is. So I would say, yes, we're consistent with other states because it's a standard of medical practice.
Right.
It has evolved some over time, as many things do, but it's a compounded prescription that is going to So it's a number of medications, and those medications then have to be mixed with water when it's time. So they come in a powdered form
Oh,
and drunk quickly. It's something that addresses, and usually you take something for nausea or something ahead of time. And you get ready by not having a heavy meal and all of that stuff. But it's helps anxiety. And what happens first is it puts you to sleep. So usually within minutes, a couple of minutes, someone, after you drink this, you would fall asleep. Within a short time thereafter, slip into actually a coma. And then the medication then actually stops your heart eventually. So it can be a matter of 20, 30 minutes altogether, or a couple of hours, some people longer. And the medication can be adjusted slightly depending on your particular circumstance. So if you have gastrointestinal issues, and so they're worried about absorption, you may get more of something or less of another thing. And also, in addition, I think there's some anti-seizure medication added in there. So I'm not the expert on exactly what it is, but it is compounded, and you mix it with a liquid, apple juice or something. It's a little bitter, so people often have a little sorbet or something to take away the bitter taste. And within minutes, within 10 minutes, probably you fall asleep.
Chris, the place to really get the information on how it goes down and really the getting into the weeds as much as you care to is really this American Clinicians Academy on Medical Aid and Dying, ACABAID. Just Google it, and there's just a wealth of information. They are the ones that are really sort of keeping the science going through their collective wisdom of people all over the country who are doing this work. So that would be the place to get as much detail as you want. Thanks.
yeah, thank you for the overview. It sounds like a very well thought out, curated experience, and it does sound like it would be quite peaceful. So,
right.
So
50 years of experience combined throughout the US.
Right.
Thank you, Chris.
Thank you.
Besides being Final Exit's surrogate consultant, and I did spend an hour, not yesterday, but the day before, talking about picking an effective surrogate. But my question is really, I do end of life counseling, and I live in Arizona, which does not have medical aid in dying. And the question I get pretty often is, well, where can I go if I want it? And I think your model is like the best, as far as from what I'm hearing in my circles, that you are now the benchmark for medical aid and dying laws. How strict is the residency? I mean, what would somebody, if I was sending a client there, and what would they have to do in order to establish residency in order to take advantage of the law?
So residency is not defined in the law. So it's a matter of, I think, satisfying the prescriber that your intent is to be living in New Mexico. And so there's not a certain time that you have to be here, or certain documents you have to show, but it has to be fairly clear to the prescriber that you have left your state of origin and you have moved here. So it's not a vacation destination for this purpose. You can't just show up on the weekend and that. So you have to establish with a provider. They may need a consultant, or you've enrolled in hospice. You may have moved in with a family member. You don't have to show that you have, a mortgage or rent or paying utilities, none of that, because you very well may have moved in with a friend or family for the end of your life. But you have to establish yourself with a doctor, hopefully, because I think it provides a lot of help. Enroll in hospice. Those kinds of things aren't going to have anyone question that you are living here now.
All right, great. Thank you so much.
Yes, thank you, Debbie. Thank you, Barak. This was an awesome session. Our next session will be starting in 30 minutes with Todd Van Beck, who is a funeral educator and incredible speaker. He's going to be speaking on, the title of his talk is Grumpy, Cranky, Fussy, the Unspoken Symptoms of Grief. You will learn a lot in that session. So take a quick break and we'll see you back online here very soon.